So I guess I'll give a little bit of background with Healthcare Logics. We started Healthcare Logics on the USNS Comfort when it was here. We basically saw that there were a lot of underlying issues, that it wasn't just necessarily COVID, but it was things leading up to it, where diabetes or heart conditions or things that weren't really necessarily being treated, just kind of a Band-Aid put on situations. So we felt that if we were able to help with chronic care management and remote patient monitoring, so that's how Healthcare Logics got started. So we are the first of its kind, as it says on the sign. We are a virtual clinic. What that means basically is that we don't have a site where people come to us, we go to them. So we do home visits, we do site visits, as such as this. We do testing, we do blood tests, we do telehealth visit, anything that might be needed for that patient's health and wellness. We also do, patient advocacy, so we will send a patient to the hospital if need be, but we will monitor and make sure that they're getting the best care possible. Not that the hospitals don't, but we just want to, be on top of that. So that's actually our first slide a little bit. So what we do is we make it that there's, we come to the schools, we come to office buildings, so there's no, long lines. Somebody's not feeling well, they shouldn't be standing outside in the freezing cold waiting to get a test to see what they're not feeling well from. I've had even friends who have gone online, they're not feeling well, they're sitting there in the bitter cold for 4 hours, suddenly their bronchitis turned to pneumonia, so it's things like that. We just want to make sure to avoid that, so we come to you especially if you're not feeling well. Or we will have you come to us but stay in your car and we'll do testing, we'll do monitoring, make sure that the person's okay. So as you can see, we do the latest technology. We utilize the latest technology for remote patient monitoring. We have all of our professionals are professional, they are trained. So they're not just trained in the technology that we're using, but they're also trained in more of a mental health way. So what we do is we really train people for the compassion and the understanding that needs to be. And actually, Superintendent, when you were discussing about the community, that's our biggest thing, is really we are a community. We all have to work together. We all should work together in a nice way. So that's how we train our staff, that we're all in this together, and we do everything. So we have, like I said, the in-home visits, the on-site medical visits. With some of the school districts that we work with, we actually are the on-site clinical. So what that means is we have like clinical hours where if somebody's not feeling well, they know they can come to us, and we get like a little desk and chair, and we kind of just assess what's going on and make sure, A, that it's not COVID, and B, that whatever it is, we do treat and we make sure that it's okay. We do have physicians that are with us, so our physicians are able to do an assessment as well if antibiotics are needed or anything like that. So, and anything, obviously, if it's for a student, it's with parent notification and permission, and we make sure that we're within our realm of whatever's going on. So we do the lab testing, we do also medical education. So that'll be a little bit later in the presentation as well, where it explains, we like to explain things. We don't just, oh, you need this. Why? Well, you just need it. Just trust me, I'm a medical professional. We like to explain, because the fear a lot of times of what's going on, what's being done to me, what's happening, also can lower people's immune systems. It also can, kind of lead to other things that aren't so great, or like other decisions that somebody would make out of fear. So we want to make sure that they understand what's going on from soup to nuts. Every patient gets, full medical education of what's happening. We do administer flu shots and all of that stuff too. So this is where the education comes into play. So basically, I wanted to go over a little bit what a virus is exactly, so that everyone understands what we're looking for and what we're fighting against, so to speak. So a virus is a parasitical organism that made its way into the human body. So what that means basically is that it goes into the cell and it parasites off the cell. So it starts feeding off of it. And that's what we like to call the exposure. That when somebody is exposed to a virus, it's first sitting and it's incubating. So it's feeding off the cell, it's growing bigger, it's getting larger, it's getting stronger. During that incubation time, it's emitting a fog. It's kind of pushing it out. So that also we'll touch base on a little bit later, and that'll explain the testing, why we do the testing the way we do it. Okay, so this is a little bit of just how a virus works. So it explains how it goes into the cell. It, parasites, and then it breaks out of the cell, and that's considered the infection. The actual infection is when it's out in the body in its full form. Sorry. Okay, so what do we look for in a virus to see how dangerous it is, or what we're dealing with? So the first thing is the incubation period. The incubation period will tell us how long our body has, basically, in order to fight the virus before we get infected. So the incubation period is that time when it's manifesting, it's parasiting, and it's kind of just sitting in one location, just building up. So that's when the body has time to build up some antibodies before it actually infects the person and goes into full force. The other thing that we look for is the mutation rate. So any virus that you see, HIV is the longest line, that's the hardest to treat because it has the largest mutation rate. So every time we get close to a vaccine, it mutates, or even not even close to a vaccine. We don't know, we can't really get ahead of the curve. So the whole concept behind vaccines, such as like the flu vaccine, is basically we're trying to get ahead of the curve. We're trying to guess what the next mutation will be so we can fight it, so we can get ahead of it. So that's, how that works. So with certain viruses, obviously we can't. So this is the immune system, just kind of an overview of all the different components. I apologize, I'm not going to go into like all of it, but basically the next part shows. So there's acquired immune system, there's innate immune system. So this is just a quick overview, of all of this and how this all works. And we basically build up immune system when we are exposed to certain things. Once we're even infected with things, it kind of builds up the immune system. We get certain things from, when we're babies, and certain things from when we're older, certain from vaccines, and certain things from the community. So that's where herd immunity comes in, where, basically we get protected by the community's immune system. So this is just in a nutshell. If anybody does want this, I can always send these over. I find it interesting. So how is COVID different from all these other viruses that we just mentioned, that we just saw? So COVID, so normal viruses will affect the upper respiratory system. So the cold, even the flu at times, certain flus, they actually, affect the upper respiratory. So it's all up in the facial and the throat area. With COVID, the difference is COVID actually affects the lower respiratory system. So why is this so important? Because what we're concerned about is not necessarily COVID itself. We're concerned about what COVID causes. COVID actually causes a lot of times pneumonia because it's in the lower respiratory. So that's where we get concerned, and that's where we want to make sure that if somebody does have COVID or they do have, anything in the lower respiratory, we want to make sure it does not evolve, and that's where most of the patients end up on respirators, and we want to make sure to clear out the lungs and make sure that viral pneumonia is very difficult to treat, and that's what our concern is, and that's why we treat it so vigilantly the way we do. So, with us, how does it work with the testing? So what we do, we have, like I said, our trained testers will come in, they unseal everything in front of you. So this way everything is sterile, everything is clean. Then they take the swab, it's presented over to the patient themselves, they take the swab out. Now the reason for this is also to protect my testers. So if I'm sitting on top of somebody and I'm shoving something in their mouth or shoving something up their nose and they sneeze or they cough on me, my day is over. That's it. I have to go home. I have to shower, change, burn my clothes, do whatever I have to do. And the other thing is that it also puts me at risk. So now that person sneezed on me, coughed on me, whatever the case may be. So the saliva is the most potent. So if somebody is not feeling well, or they're not even not knowing that they're not feeling well, and they did that, it can infect one of our testers. So what we do is we kind of take a step back. We also do gauge it based on the person's age and, their capacity, what we feel. So if it's a child, obviously we're going to be there and, assist them and help them with the swab. But if it's an adult and they're capable, we hand them the swab. They then take it, they put it under their tongue, they keep it there. So the concept is the fresh saliva pool that's coming in over there is going to mix with, let me actually backtrack a little bit. COVID starts in the throat. We are concerned that it goes down into the lower respiratory, but it actually starts in the back of the throat. And so remember when I mentioned the fog that gets pushed out? That fog actually has baby virus in it. That baby virus is what we're trying to catch right there with the swab. So the swab sits there. Now, the person has a swab in their mouth is closed. Psychologically, they don't swallow because they have something sitting there and they're, kind of staying still. They also don't open their mouths and they don't talk. It's very funny. But they basically sit there and they just keep it there. Then also because there's something there, it's creating more saliva. So what that saliva is doing is it's going all around the mouth, going all around the different areas, and the swab is actually soaking in a clean catch, we call it. So I'm sure you guys have seen the spit test, I call it, the saliva test, where they spit into a cup. That is not a clean catch. That they still have to bring it back to the lab and they have to siphon it and they have to go through it and they have to, that takes an extra 2 days for them to do that with each specimen. And two, it's not as efficient, not as effective because you're siphoning. Who knows you're siphoning out the virus if you're doing that. So we get a clean catch where it goes on it kind of gets soaked into the swab. Then the patient themselves will take it, put it into, there's a little serum, which I'll show you guys in a little bit, but there is a little serum there. They put it in, we then break off the top, seal it up, and send it off to the lab. So it's a pretty simple process from start to finish, and it's also less traumatizing. I can't tell you the amount of homes I walked into, and the second they see me, the children in particular, and I've had some adults, don't get me wrong, but will literally sit in the corner cowering, hysterically crying, no, 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 they are not touching me. That's heartbreaking. I have 3 children of my own, and I see their reaction as well when they have to go to their school testings. And it hurts, as a mom. So we understand that, and that's another thing that we kind of took into account, and we said, let's see the best way that we can get the best, results, and the best way that we can make sure that people are not hurt by it mentally and physically.
Danielle, sorry to interrupt. How long would you say it stays under the tongue, just so we can give people an idea of how long that process might take?
So, you know how they say to sing the ABCs when watching? So I kind of like hum a little elevator music, the ABCs a little bit, so it's about 20 seconds that they're keeping it under there. But yeah. Not the best voice, so just don't. But yeah, so we do about 20 seconds that it's under there, so that way we get enough of a catch and we make sure that we're kind of getting everything. And that's, pain-free and accurate. Speaking of the accuracy, there's a lot of talk that the nasal is actually more accurate. I don't want to, the research is the research, and it is what it is, but it's actually the mouth, the way that we do it is actually more accurate, and especially for early detection. The reason for that is there's a very high rate of contamination with the nasals. So if you get the skin cells, you get blood, you get whatever, which happens a lot, especially with elderly and the young ones. Middle age, is not as worried about that, but it's basically, there's a lot of contamination, high contamination rate. So with us, we actually monitor, we make sure that it's not touching anything else. We have them remove the mask completely so that they're not touching the mask in any way. We make sure that we negate that contamination. So that's where the accuracy kind of comes in. Plus, remember when I mentioned about the infection versus the exposure. Exposure, it's sitting there already. So it's emitting that fog. we're actually have a very high rate of catching it when someone's been exposed already, as opposed to when they're already kind of showing symptoms and infecting others. So we're able to kind of catch it right before, to try to stop the spread. And we do typically get results back pretty quickly. We work with a few labs, one of which is Northwell. Northwell is, proud to say, the only lab in the entire country that has a rapid PCR machine. And it's about huge, like billion-dollar machine. Over-exaggerating, I don't know how much it costs. But basically, they're the only ones, and they're able to get us results very, very quickly. And that's it. And that is my contact information. Everyone is more than welcome to speak with me if they have any questions. I know we're going to take questions here as well, but any questions, any comments, anything, oh, and I'm sorry, you did mention, I'm sorry, Ms. President, about the reporting. So yes, all reporting is done through us. We make sure that one of the things that when we first started, like I said, it was chronic care management, it was remote patient monitoring. We were asked to step in and help out with the COVID testing. And one of the arrangements that we made is we are doing the reporting. We're gonna do the tracing for all of our patients. Somebody comes up positive, we're gonna give them a call ourselves, and we're gonna kind of, so who are you around? Which party is he going to? Things like that. So we want to make sure that it's more of a personal touch. Plus, we're face-to-face with them, as opposed to, someone outside calling and asking the same information that we already have. So.
I mean, you're also making those reports to the state to let them know that you have fulfilled the 20%. And working with our district medical professional for the contact tracing on what's happening on the inside, who's sitting where.
Exactly.
So there's still the connection. We're not operating separately from each other, but more in conjunction with one another.
Yes. We come in, and as I always say, we are as much of a Yenta or not as you guys want us to be. Okay. So we come in, we work with you guys, we follow your lead. You want us to come in and test 2 people, you want us to come in and test 500 people, whatever the case may be. And then we do share the results, and we do speak. One thing I do want to point out is the intake sheet that you had mentioned. A lot of people ask this question. So at the bottom of the intake sheet, that signature is allowing us to have that communication with you guys, because there are HIPAA laws, and we do follow all the HIPAA laws. So anything COVID related that is being done on site is discussed, and it is explained in that paragraph at the bottom.
Superintendent Chang mentioned this on his live stream today, but I just want to reiterate. If somebody decides not to consent, that does not mean that they would be excluded from school. So there was confusion about that. We tried to be clear in that form, but again, we would need 20% of the population to participate, but that wouldn't mean that if you did not give the consent that your child would be excluded from school. So that's an important point we want to reiterate. If we could for a moment talk about what cost this might be to parents or families. So it's a no cost to the district right now. We've let our parents know through the consent form that HCL works directly with the insurance carriers. We saw in our contract and had talked about the fact that if somebody was without insurance, they would not be turned away from testing. But could you talk a little bit about that? Because I want to make sure people understand what their implications may be as an insurance carrier. Is there implications for them to be tested with HCL versus a city MD? Is there a difference, and how does it affect their insurance? I think we need to get that clear for people.
Sure. So, yeah, there is a few differences, all good, I like to think, but they get more of that personal touch. They get, where one-on-one they become, we welcome them into the Healthcare Logics family. But in regards to insurances, we accept whatever the insurance gives us. We will never go to the parents or to the patient and say, look, insurance didn't pay $200, we pony it up. We never do that. We don't even do that on a good day when it's not COVID. And in regards to anything COVID testing, Northwell has already put in writing to us that everything COVID is covered. No matter what, they will never go after a patient for COVID. So any COVID related anything. We do ask, so one of the things is that it does go through the Federal Care Act. Federal Care Act did kind of divvy up a little bit to the insurances. So if somebody does have insurance and they don't put it down, then they may receive a bill because there is a database that shows that they do have insurance. So we just have to go through the proper channels in order to get the funding. And it's more so the lab than us, because if they deny us, they deny us. So we accept that, and we're good with that. So we do, it is really equal to all. We want everyone to get the best healthcare possible. That goes for our home visits, that goes for our everything. If somebody doesn't have insurance, it doesn't mean that they shouldn't get the best care possible. So we do give the same care to everyone.
Thank you. So just also understanding the compiling of the 20%, if 15% of that 20 come through HCL and get tested on site at our facilities, but there is 5% of the people that do it on their own, how do we then compile that information to satisfy the state's 20%? Because the consent form we're sending out right now is really for HCL.
Yes.
It's not a general consent form. So I want people to understand that HCL is an option to them, but if they did go outside, we could still count them as part of that population of people that we could count on to make our 20%. So could you explain how that might work for us?
Sure. So in regards to things like that, if somebody does go outside, we just ask to see the results. We do not accept rapids as an option. So we do ask to see the PCR results and that it was actually a PCR. Other than that, then we just put them as part of the 20% and we report it to the state.
Okay.
That's it.
Thank you. I'd open up to the board for any questions for Ms. Siegel. Mrs. Berry?
I think you answered my main question was about towards the end when you said about the reporting and the contact tracing, just making sure that we're communicating that with the district and that we're in sync so that parents are getting the same information and that the district medical professional is getting the same information. So that was my main concern. So I think that was covered. Thank you.
Thank you. Ms. Barazani?
I just had a question. Do you know the cost per test that the company is going to bill private insurance?
I don't. I apologize because there are two billings that happen. It is the lab and it is us. My biller actually handles all that, so I have yet to see any of the bills that go out.
Okay, because if there's a difference between what a private insurance company is billed, I understand you're saying there won't be any cost, meaning the company's not going to come after people personally for money, but the insurance company would be responsible for paying.
So no, actually what happens is the insurance companies will not send out bills. They send out, if you notice what the insurance company sends you, it's just a synopsis. They sit there and they'll tell you, we did not cover this. Nowhere in there is it saying you now owe us this money.
Right, no, I'm not saying that. I'm saying the cost per test to each individual will be different for different insurance companies versus people who are covered under government insurance?
No, it's all the same thing that goes out, and like I said, whatever they bring back, they bring back. It's a flat rate, whatever it is. I apologize. I will look into that, and I will get back to you guys with the exact amount, but I do the clinical, I leave the billing and all the financials to
But it's a
my partner.
standardized amount for each test?
Yes.
It doesn't vary?
No.
Okay.
Yeah, there's one, it's a code that we put in. So when I write up the orders, I just put in a code. And that code is whatever, the amount that's associated with that.
Any other questions, Ms. Barazani?
No.
Okay, Mrs. Dion?
Just again, following up on the billing, because I think there was some concern in our conversation at our last meeting. It's January, whatever the date is anymore. So it's a new year and everybody now has to fulfill their deductibles. What happens there? So I haven't done my deductible and you're gonna bill my insurance company and they're gonna say, nope, it's 2021, give us, we don't cover this.
So this is actually, like I said, this is covered under the Federal Care Act, so it doesn't affect the deductible at all. So basically what happens is they give like grant money, we call it, I don't know, that's what I call it. So it's basically, and there are rules to it. It has to go to COVID, they're not allowed to charge copays, and it doesn't affect the deductibles or anything like that. So that's, kind of, and even somebody who doesn't have insurance, the lab is still getting paid through the Federal Care Act. It may be less, it may be more, I don't even know, but they are still getting paid, so all bills are covered when it comes to COVID testing.
Wonderful, thank you. There was also some question about the number of students or staff that we actually, who volunteer to do this. If we only have, let's say, 20%, are we going to be testing kids again and again if we go into one of these zones?
So generally, we do have to get up to that 20% to show that we're compliant. We have not seen in any school, I mean, I have to say I've seen more. We just had one this morning where we did over 100 of the staff that only, I think 30 of them signed up to actually come in. While we were there, they, oh, can I come? There was no, slot. We have yet to have where we don't go over the 20%.
Okay,
So
that's good to hear also.
yeah, if we ever did come across it, I'm definitely open to, speak with you guys and see based on your knowledge of your students and your staff, what you think would be a good solution.
Okay. And you said you will have testing people. Will we have the same people all the time?
Generally, we do try to keep it that way, mostly also because when dealing with young children, that, standard, having the same person all the time, it's a comfort to them. So again, the same thing with the swabbing, and we do look at the mental health to make sure that everyone is coming out of this on the other end mentally healthy.
Wonderful. I think that's all I have. Thank you.
If we're put into one of the zones, I remember reading in the contract, you can be up and running pretty quickly with us, correct? Because I know we have the 2-week window, but I think we'll all feel a great sense of accomplishment if we can get that underway. So we liked that you were making yourselves available to us in those first few days if we did get the designation. So just to reiterate for the community, if we were put into that one of those zones, messaging would come out from the district right away, letting them know. But that's why it's so important ahead of hopefully that not happening to us ever. We have those consent forms filled out. So please revisit the emails that were sent from the district. Again, I'm assuming they're accessible to find on our website as well. But even had you replied to the survey, please fill out the consent form. We really do thank you for coming this evening, for being a partner with us, and for offering our community this opportunity to have convenient testing done right on site. One thing I think we spoke about very briefly, and I just want to also remind parents is, especially for the young ones, there are opportunities for parents to be there with their child. That was something that was concerning. The consent forms, I think it was 16 and under, the parents had to sign, or was it 18? 18 and under?
We made it 18, yeah.
18, but for many of us who have the elementary school students, the parents would have that opportunity to be there alongside of their child. We wouldn't just be grabbing children out of classes. They wouldn't have any idea what was going on. Parents wouldn't know. It would be the opposite. We would be making this as smooth and comfortable as possible for everybody involved. And we thank you for all of that and the TLC that we could see that you would be giving our students and staff. So again, if there's no other questions, we just will say thank you so much, and we're happy to be a partner with you. And though we love having you, we hope to not be seeing you very often over the next 6 months or so.
That's it.
But thank you very much.
Anytime. Thank you, guys.
Thank you.
It's a pleasure.